This presentation is on drugs used to treat skin disorders. So these are the drugs that we'll be talking about in this presentation, starting with the anti-infectives. So basic principles when you're prescribing an anti-infective of some sort, whether it be bacterial, antibacterial, or antifungal. Basic principles that you need to know are to try to determine what the pathogen is. Of course, that's goes without saying. If you're not sure, culturing is the best. But we often are in a position where we need to treat empirically. Of course, we need to await response. When we are looking at anti-infectives, we can determine whether they're bacteriostatic or bactericidal. Bactericidal means that they're capable of killing bacteria outright. If they're bacteriostatic, they can stop the bacteria from reproducing, but they don't really kill them. One example is bacitracin that can be actually bacteriostatic, but also bactericidal, depending on the antibiotic concentration and depending on the susceptibility of the organism. Altobax is bacteriostatic against Staph aureus and Staph pyogenes by inhibiting protein synthesis. Mupirocin has wide range of coverage against gram-positive bacteria, including MRSA, but it has limited gram-negative coverage. And polymyxin has bactericidal activity against some gram-negative organisms, including those that you see listed there. Now we'll look at how we approach treatment of bacterial skin infections. Okay, we'll start with impetigo. We could use mupirocin, which is Bactroban 3 times a day. Altobax is BID for 5 days. For superficial wound infections, we can use bacitracin 2 to 5 times a day until it appears to be clear. So if a patient has, say, an abrasion that is very superficial, we can just advise them to use bacitracin, or they can use double or triple antibiotics. When there is an indication for systemic treatment, which would be when there are more than 5 lesions or if there's no improvement in 2 to 3 days, we should use oral antibiotics. Generally, Keflex, Augmentin, and dicloxacillin are used. For MRSA, we do need to know what our local resistance patterns are, what we're seeing in our community. But clindamycin, Bactrim, and doxycycline are generally good coverage for MRSA. If a patient is a nasal MRSA carrier, we can use intranasal mupirocin, a gram BID for 5 days, but we cannot use Altobax intranasally. Next, we'll go to antifungals. Fungal infections can be classified as either dermatophytes or yeasts, and dermatophytes are actually named according to their location. For example, Tinea corporis, which is ringworm, which is the common term, and Tinea pedis, or athlete's feet, is specific to the feet, and this is how we name these infections. These infections may be superficial or systemic. Superficial fungal infections have a variety of treatments. For dermatophytes, all of the types of antifungals can be used, the azoles, the allylamines, benzylamine. For yeast, we specifically need to use azoles, and those examples are itraconazole, ketoconazole, and fluconazole. And these azoles can also be used to treat seborrheic dermatitis. Systemic antifungal infection or antifungals can also be used for fungal infections of the skin. Griseofulvin is used for Tinea capitis. Topicals do not work well for Tinea capitis, which of course involves the head and the scalp. Also, onychomycosis requires systemic antibiotics to penetrate those nails to fight infection of the nail. You can't use topicals on someone who has onychomycosis. Azoles can treat, as I said, yeast and dermatophytes. Examples of those would be Nizoral, Sporanox, and Diflucan. And terbinafine or Lamisil can treat tinea capitis, tinea corporis, tinea pedis, and onychomycosis. Some precautions with antifungals. With topicals, there are a few contraindications due to minimal absorption. Most are safe in pregnancy. With systemics, all should be used cautiously in patients with liver problems. And also caution in pregnancy. Terbinafine tends to be safer in pregnancy. Griseofulvin has some possible cross-sensitivity with penicillins. Some ADRs and drug interactions. ADRs for topicals are generally hypersensitivity reactions. With systemics, we do have to be concerned about hepatotoxicity, and griseofulvin can exacerbate lupus. Also, terbinafine, as I mentioned, is safer in pregnancy, but generally the side effects are GI. There are few interactions with topical antifungals, but with systemics, there are a number of interactions, especially with griseofulvin. It can exacerbate hepatic metabolism of a number of drugs. It can interfere with oral contraceptives, and it can actually decrease the effectiveness of warfarin, where we see with antibiotics, it will increase the INR. In this case, we can have a decreased INR when we use griseofulvin with warfarin. Terbinafine clearance can be affected by a number of medications, and it can also have the rare side effect of Stevens-Johnson syndrome. Next, we'll talk about specific fungal infections. Candidiasis can cause Candida intertrigo, which occurs in the skin folds. For example, women tend to get candidal infections underneath the breasts because if the breasts are large and they come in contact with the skin of the trunk, you can get a yeast infection. We can use over-the-counter or prescription azoles for that. Fluconazole can be used for oral thrush or for vaginal candidiasis. Tinea capitis, which involves the scalp, generally needs to have systemic treatment with griseofulvin or terbinafine. However, you could use sporicidal shampoos such as selenium sulfide and ketoconazole, but generally it's not going to be as effective as treating systemically. Tinea corporis involves the body, as I said, and a common name for that is ringworm. You can use topical azoles or topical allylamine, which is Naftin, also a drug called cyclopirox or Loprox. Can be used for tinea corporis. Tinea curis involves the groin. Topical azoles are used for that. Tinea pedis involves the feet, commonly called athlete's foot. And we use topical azoles for that. Treatment is generally for 4 weeks. Tinea versicolor is a condition in which what we notice are white spots on generally the trunk or the face. The white spots are actually caused by an interference of melanin production by the fungus itself. So that when patients are exposed to the sun, they'll tan in the areas that are healthy, but where the fungus is infecting the skin, you'll see white spots because of that interference of melanin production. You can actually use selenium sulfide shampoo as a lotion. The patient spreads it on their body on all the affected areas, keeps it on for about 2 hours, and then washes it off. Also, of course, topical antifungals such as ketoconazole are effective for tinea versicolor. Onychomycosis, another name for that is tinea unguum, which involves the nails, so a fungal infection of the nails. Usually are treated systemically. There's one topical treatment, Penlac, which may be effective, but generally we're going to use systemic antifungals. If it affects the fingernails, it's generally going to be 6 weeks, and if it's toenails, it's generally going to be 12 weeks of treatment. It does take several months to clear. So generally it takes about 6 months for a nail to be completely grown out, and the patient really can't tell whether treatment is effective until they wait a good 6 months for that nail to completely grow out. Monitoring of antifungals, the systemic antifungals, we need to look at liver enzymes with almost all of these drugs used systemically. Also, some of them we should be aware of blood count, especially in patients that are immunocompromised. They can develop neutropenia, agranulocytosis, or pancytopenia. Next, we'll look at acne medication. And acne is classified as mild, moderate, or severe, and we're going to choose topical agents generally when it's mild or moderate, oral agents when it's moderate to severe acne. Topical retinoids, tretinoin, Retin-A, adapalene or differin, and then tazarotene or Tazorac. Tretinoin is a naturally occurring derivative of vitamin A. Adapalene is a topical retinoid-like drug that can be used to treat mild to moderate acne. Tazorac is a retinoid, and the exact mechanism of Tazorac in the treatment of acne is not really well defined. It is believed that the drug works by normalizing epidermal differentiation and by reducing the influx of inflammatory cells into the skin. So the retinoids can reduce cohesion between the keratinized cells. They can prevent microcomedones and new comedones forming. They can actually be used, as we know, for cosmetic purposes to decrease the fine wrinkles that occur with sun damage. And they can enhance the absorption of other topical agents, such as topical antibiotics. They do not work against P. acnes, the bacterium that can cause acne. They are generally applied once a day, and if the patient has very sensitive skin, every other day might be recommended because they can cause a lot of inflammation, irritation, especially when a patient is exposed to the sun. Topical antibiotics are active against the P. acnes bacteria, but resistance may develop, and actually benzoyl peroxide, which is just an over-the-counter medication that anyone can get, can actually have the least amount of resistance against P. acnes. We can also use erythromycin topically, clindamycin topically. We can use combination products, which is usually what I would recommend. A benzoyl peroxide antibiotic gel works well. And metronidazole is used for acne rosacea. Systemic retinoids, what used to be called Accutane, which is actually that brand is no longer in the U.S., isotretinoin. These are used for patients that have really severe nodular cystic acne. Isotretinoin is an isomer of all trans-retinoic acid, and that's a metabolite of retinol or vitamin A. It reduces sebum production, and it can normalize follicular keratinization. Unfortunately, it has some severe ADRs, and pregnancy is a complete contraindication. It's what used to be called pregnancy category X. So fetal exposure is absolutely not recommended. It can also cause cheilitis or fissures around the mouth, hypertriglyceridemia. There can be CNS effects, including headache, lethargy, and fatigue. Liver enzyme and lipid levels need to be monitored. There is restricted distribution in the United States. Providers and pharmacies that actually dispense need to be registered with a program called iPledge, and that's to minimize fetal exposure. So you need to make sure the patient is not pregnant. You need to check for pregnancy at the start of treatment. Also needs to be monitored throughout treatment. The patient needs to be on a very reliable method of contraception. So the black box warning is for pregnancy and multiple birth defects. Now we'll talk about how we approach acne treatment. The topical retinoids are used to treat inflammatory and non-inflammatory acne. But initially, the acne may worsen. And there's a lot of concern about redness and peeling of the skin, and especially in times of sun exposure. So initiating this topical retinoids in the summer is probably not a good idea. So you want to make sure the patient understands that, for one, the acne might look worse initially, but also they're going to be distressed over the redness and peeling of the skin that can occur, especially with sun exposure. Topical antibiotics are used to control acne by their bacteriostatic or bactericidal activity against P. acnes. Benzoyl peroxide, as I said, is available over the counter. Erythromycin and clindamycin are topical antibiotics that can be used, especially in combination with benzoyl peroxide. Oral agents such as oral antibiotics are very effective in treating the P. acnes colonization. We can use the tetracyclines, also erythromycin orally can work as well as topically. Hormonal therapy for women, oral contraceptives generally go a long way in helping to control the inflammatory component of acne. And then retinoid isotretinoin, as I said, you need to be enrolled in the iPledge program. This is generally prescribed by dermatologists, and we use this for severe nodular acne. Acne rosacea is a condition that generally affects middle-aged patients. It's a chronic inflammatory disorder of the blood vessels, as well as the pilosebaceous glands of the face. We generally see the large vessels around the nose. Can be quite distressing, can be exacerbated by alcohol or stress sometimes, exposure to the cold. So treatment is with a topical metronidazole, such as Metrogel. It's a bactericidal that disrupts the DNA and inhibits nucleic acid synthesis. And this is generally a lifelong treatment. Now we're going to move away from anti-infectives to topical corticosteroids. And the corticosteroids act against most causes of inflammation, whether it be mechanical, chemical, microbiological, immunological. And at the cellular level, they appear to inhibit the formation and release and activity of mediators of inflammation, such as the prostaglandins, the kinins, the antihistamines. And when they're applied to inflamed skin, they can inhibit the migration of macrophages and leukocytes into the area by reversing vascular dilatation and permeability. So they have nonspecific anti-inflammatory effects, and absorption varies according to the drug used or the vehicle, such as ointments, creams, lotions. And high dose or over large areas may cause some systemic steroid effects. So if we're using high potency corticosteroids, or if they're spread over large areas of the body, we can see some of the systemic effects that we see with oral corticosteroids. So the topical corticosteroids are used for a variety of inflammatory skin conditions. We always want to use the lowest dose that is effective for the shortest period of time. And in any drug book, you can find a potency table listing all the topical corticosteroids. Sometimes it's even prudent to use, say, a low potency or intermediate potency with a higher potency. For example, if you're treating something that's chronic, such as atopic dermatitis, there may be times when you can get away with using a lower potency corticosteroid, but at other times when they have a flare-up where they might need a more potent steroid. So they also, could be considered is using intermittent dosing or intermittent applications. Again, like if you're using topical corticosteroids on the skin for a long period of time, you may have some skin atrophy, so you want to minimize the amount of drug use if possible. If you're using a high potency corticosteroid, you do want to be aware that abruptly discontinuing it can have some rebound effect. So if you have the patient using a high potency, for example, and then you abruptly stopped it stop it, they'll have a flare-up of their atopic dermatitis, for example. So you want to taper off by switching to lower potency and or decreasing the frequency of the application. So some precautions that we need to be aware of with corticosteroids, they are contraindicated as monotherapy when there is a primary bacterial infection. So you don't want to use them in acne vulgaris. You don't want to use them in other kinds of bacterial infections because it'll worsen the bacteria. You don't use it in treatment of rosacea. There is some caution with pregnancy and lactation, but again, that would depend on how long you're treating, what the surface area is, how much surface area you're treating, and the potency of the steroid that you're using. Children might be more susceptible to the effects of topical steroids because they have a larger body surface area compared to weight. So they may tend to absorb more systemically. So in infants and children, we want to use the lowest effective strength of topical steroid that we can get away with. So the use of high potency or very high potency agents should be avoided. Children are more susceptible to HPA axis suppression, Cushing syndrome, intracranial hypertension. So we do need to be aware that children are, while we think we're okay with something topical, we may have more concerns with the use in children. So these are some of the indications for topical corticosteroids, and we'll look at some of these individually. Dermatitis, atopic dermatitis or eczematous dermatitis or eczema as it's commonly called. We can use long-term corticosteroids. Again, as I said, you may want to use those off and on, intermittently, whenever possible. But when patients have an acute exacerbation, they're certainly going to need a fairly high potency corticosteroid. So they come, as I said, in low, intermediate, high, and super high potency. Again, you want to avoid the high or super high potency in children. You can also use corticosteroids to treat atopic dermatitis orally. That sometimes can be used intermittently when there's a really bad flare-up. When you use corticosteroids orally in patients with atopic dermatitis, you can expect to see that rebound effect. So you need to use a declining dose, as we always do when we're using it for a long period of time, as opposed to like a short burst for 5 days or so. But you also want to consider switching to topical, going from a higher potent to a lower potent before you actually stop it. Immunomodulators such as Elidel and Protopic can also be used. They can be used as second line after topical corticosteroids, but there is a black box warning regarding rare malignancy concerns. And generally that is going to be more of a concern when you use it for a long period of time in one area. Antipyretics can also be used to treat atopic derm, such as oral antihistamines, doxepin, Aveeno cream or some types of cream or Aveeno bath can also be effective, emollients. Antibiotics may need to be used in atopic dermatitis when there is a secondary infection. For example, when the patient scratches a lot, and sometimes that occurs without them even being aware at night when they're sleeping. Children also will scratch, and it'll be hard to keep them from doing a lot of scratching, which can cause a secondary bacterial infection. Contact dermatitis, an example of that we see commonly is poison ivy dermatitis. Topical corticosteroids can be used if it's limited area, if there is a big systemic reaction and the patient has lesions over a good part of the body, we're going to use oral corticosteroids. And generally, we're going to use prednisone, and we treat for 2 to 3 weeks. If you use something for a shorter period of time, like the Medrol dose pack, you'll often see a recurrence. Once you stop the Medrol dose pack, it comes back. They get a rebound. Wet dressings or baths can also be used, such as Dome Burrows or Burrows solution. That can be a wet dressing that's applied for 30 minutes several times a day. And then a vino bath, colloidal oatmeal solid baths can also be helpful, or oils um, as an adjunct to using steroids. Um, if you use corticosteroids, you don't get as much rebound with contact as we can get with atopic, unless, as I said, you use that medrol dose pack, which is not long enough, and generally you will see a rebound. Another type of dermatitis is seborrheic dermatitis. There are anti-seborrheic shampoos that are used topically. Again, selenium sulfide can be used for this, as well as ketoconazole. Generally, you tell the patient to shampoo twice a week. You can also use topical corticosteroids to treat seborrheic dermatitis when it's on the skin. And generally, we use a low potency corticosteroid that doesn't, if the patient does not respond to shampoo alone. Psoriasis can also be treated with topical corticosteroids. So as you can see, sometimes you don't really even need to know what the patient has. You can use steroids for a variety of these conditions, but of course not if it's an infectious problem. Topical, intermediate, or high potency corticosteroids are generally used for psoriasis. And generally, we use a pulse therapy approach. In other words, we may treat for a week or two and then stop, and then treat for a week or two and then stop. Again, you want to taper off to prevent rebound. This is a chronic condition, and so that is always a concern. You can use coal tar in a variety of solutions, such as creams, shampoos, ointments, lotions, etc. But you may have some photosensitivity with that. So if they're using these agents and go out in the sun, they may have more hypersensitivity to the sun. There is a monoclonal antibody now for plaque psoriasis, Taltz, which is an injectable for moderate to severe plaque psoriasis. It can target interleukin 17A, and that's a protein that plays a role in inflammation and plaque growth. But there are some cautions, especially the concern about being immunocompromised while on any monoclonal antibody. So it can worsen inflammatory bowel disease such as Crohn's or ulcerative colitis. Vitamin D3 derivatives can also be used for psoriasis. Calcipotriene regulates self-differentiation and proliferation, and it can suppress lymphocytic activity. And that's an ointment that's applied twice a day, in the morning and the evening. And Rocaltrol, which is something that you probably are more familiar with in renal patients and renal dialysis patients, can actually be used topically twice a day for psoriasis. Next, we have the topical immunomodulators, which I mentioned earlier. Elidel and Protopic. They're a class of topical medications used for short-term or intermittent long-term treatment of atopic dermatitis. Also, I think they're useful in areas where you're concerned about atrophy that can occur from using corticosteroids repetitively in one area, such as the face. They inhibit T cells, Langerhans cells, mast cells, and keratinocytes. They are generally a second-line treatment for dermatitis in immunocompetent patients if they're greater than 2 years of age. And there is a black box warning about that long-term safety concern due to rare cases of malignancy. Now let's talk about specific topical anti-seborrheic agents. Also already mentioned selenium sulfide, which is Selsun Blue shampoo, that can be used on the skin. Seborrhea is an inflammatory dermatitis that produces this greasy-looking yellowish scales, and they're on areas that are rich in sebaceous glands, such as the scalp, external ear, around the center of the face, the upper part of the trunk, and in intertriginous areas, or areas where there's skin coming in contact with skin and the skin folds. The mildest and most common form of scalp seborrheic dermatitis is dandruff. which occurs as those fine white scaliness on the scalp. But you don't see inflammation, no erythema. You can use the selenium sulfide. You can use parathione zinc, which is Head and Shoulders shampoo, ketoconazole, or sulfacetamide sodium, which has antibacterial activity against common skin organisms. Patients can use topical antihistamines and antipyretics for a number of conditions such as atopic dermatitis. Topical diphenhydramine or Benadryl might be effective. It does have a local effect on H1 receptors. You can use them for minor insect bites. You don't want to combine it with systemic diphenhydramine because that could just produce more side effects. Doxepin is another H1 and H2 receptor blocker for severe pruritus. It may cause drowsiness, as can be the case with any antihistamines. Patients can also use a variety of moisturizers, emollients, and lubricants. In fact, it is really important that patients use these in addition to more definitive treatments such as steroids. They generally eczema or atopic derm will have a very dry phase, and using these frequently, 1 to 4 times a day, can greatly reduce the amount of itching that they have. If there is a widespread area, lotions are more effective because they can just spread more easily. They're thinner because they have more water. Ointments tend to be more occlusive. So if they're have a particularly bad area, they may need ointments in a particular spot because they will adhere to the skin more for a longer period of time. Lastly, we have treatment of burns. Silver sulfadiazine, which is Silvadene cream, is generally used to treat burns that are more than just first degree. When there's actual damage to the skin, such as in second and third degree burns, you'll need a topical anti-infective, Silvadene. It's broad spectrum. 10% may be absorbed through the skin, and there can be a transient leukopenia that can occur, which generally resolves spontaneously. And this Silvadene is applied to burns once or twice a day.